So today's topic is disorders of voice and speech. Okay. So voice is produced by which part of the larynx? Chanakya? Chanakya. Chanakya. Are you able to hear me? Students?
Yes, sir.
Yeah, are you able to hear me?
Yes, sir.
Okay. What is your roll number?
59, sir.
59. What is your name?
Shreya, sir.
Shreya. Okay. So how the voice will produce? Shreya. Voice is produced by which part of the larynx?
Vocal cords, sir.
Vocal cords. Okay. So that comes under the glottis. Okay. Larynx is broadly divided into three parts: supraglottis, glottis, and the subglottis. Okay. What is the other name for the true vocal cords? True vocal cords. Shreya.
Ventricle,
Vocal
sir.
folds, sir. Vocal folds, sir.
Vocal folds. Okay. Any other name?
Ventricle, sir.
Ventricle. Not ventricle. Ventricle is a space between the false vocal cords and the true vocal cords. So that part of the larynx we call it as ventricle of the larynx. Okay. Vestibule means the part of the larynx from the laryngeal inlet to the up to the level of the false vocal cords. That is the vestibule of the larynx. Okay. Vestibule and the ventricle. Okay. Students?
Yes, sir.
Okay. So for normal production of the voice, the size of the vocal cord should be normal. Okay. Size of the vocal cord, position of the vocal cord, and the stiffness of the vocal cords, and approximation or movement of the vocal cords or adduction of the vocal cords. So all these functions should be normal. Then only we will get the normal voice, normal pleasant voice. So if there is any problem in this, suppose size of the vocal cords or position of the vocal cords, approximation of the vocal cords, stiffness of the vocal cords, so any problem, all these, any of these functions of the vocal cords, then we'll get the unpleasant voice or rough voice or low pitched voice or hoarse voice. So these are the different terminologies for the different types of the voice disorders. Okay. What is the nerve supply of the larynx? Anybody? Roll number 5. Roll number 5. Nerve supply of the larynx. Roll number 5 there. Roll number 59.
Sir, recurrent laryngeal.
Recurrent laryngeal nerve is motor or sensory?
Motor, sir.
Motor to which part of the larynx? Entire larynx or any specific part of the larynx?
Except
Cricothyroid, sir.
cricothyroid, sir.
Okay, except cricothyroid, it separates the all the muscles of the larynx. So cricothyroid is separated by
Superior laryngeal nerve, sir.
superior. Cricothyroid is separated by which nerve?
Superior
External
laryngeal nerve.
larynx.
So again in superior laryngeal nerve, two branches are there, external and the internal branch. Those are the branches of the superior laryngeal nerve. So which branch will supply the cricothyroid, external or internal?
External, sir.
Yeah, external branch of the superior laryngeal nerve will supply the cricothyroid muscle. What is the function of the cricothyroid muscle? Is it a abductor, adductor or tensor of the vocal cord? Sai Malik. Sai Malik is there?
Sir, good morning, sir.
Good morning. You have to respond. What is the
Sir,
function of the
tensor, sir.
tensor?
Tensor.
Very good. Very good. Very good. So cricothyroid function is tension of the
Tensor, sir.
vocal cord. Tensor. What about the sensory nerve supply of the larynx? Sai Malik.
Sir,
Sensory nerve supply of the larynx.
Internal laryngeal nerve, sir.
Internal laryngeal nerve. Which part of the larynx is supplied by the internal laryngeal nerve? Above the vocal cords or below the vocal cords?
Above the vocal cord,
Or
sir.
below the vocal cords?
Recurrent
Below the
laryngeal
vocal
nerve,
cords
sir.
sensory recurrent laryngeal nerve. Okay, so that is about the motor and sensory supply of the larynx. So all the muscles of the larynx is supplied by the recurrent laryngeal nerve except cricothyroid, which is supplied by the external branch of the superior laryngeal nerve. Sensory supply above the vocal cord is by the internal laryngeal nerve, which is a branch of the again superior laryngeal nerve. Below the vocal cord is supplied by the recurrent laryngeal nerve. Okay. So any laryngeal paralysis or these vocal cord paralysis will cause the voice change or hoarseness of the voice. So for normal voice production, the size should be normal, the size of the vocal cords. Can you tell the conditions where you will see the size of the vocal cord will increase, size of the vocal cord? Sai Malik.
Sir,
When you will see the size of the vocal cord is increased.
when the in
Mm.
vocal cord ulcer, sir. Not edema, sir.
Ulcer,
Edema. No, sir. Edema.
edema. Have you opened any of your textbooks? Are you seeing in textbook and answering or without seeing?
No, sir. Without seeing only, sir.
What is the name of the textbook for ENT?
Dingra, sir.
Dingra. Any other textbooks you are following?
No, sir.
Only Dingra.
Yes, sir.
Okay. So edema of the vocal cord. Is there any specific name for the edema of the
Rinky,
vocal
sir.
cords?
Rinky edema,
Rinki's
sir.
edema. Why it is called the Rinki's edema?
Because that edema is present in the rinky space, sir. It is present between mucosa and epithelial layer of vocal cord.
Just below the epithelium, there is a space that is the
rinky space.
Rinky
If the
space.
edema is present in that rinky space, it is known as rinky edema.
Okay, what is the etiology for rinky edema?
For rinky edema, don't know.
Don't know.
Mhm.
Not given in textbook.
Smoking, sir.
Huh?
Sir,
Etiology. So most of the time you will see in the smokers, smoking and voice abuse, voice misuse of the voice. So that is the reason for the rinky edema. Where do you see the size of the vocal cord will decrease? Increases edema and any tumor over the vocal cord, the size or bulk of the vocal cord will increase. Decrease, where do you see decrease? Decrease size of the vocal cord. Suppose any fibrosis post radiotherapy, if you are giving any radiotherapy for the some other disease, head and neck tumors, so post radiotherapy will see the fibrosis. Fibrosis of the vocal cords will cause the decrease in size of the vocal cord. So then we will see the hoarseness of the voice. So where do you see the stiff vocal cord? Stiffness, increased stiffness. Sai Malik,
sir,
stiff vocal cords or paralyzed vocal cords, stiff vocal cords. Where do you see stiff vocal cords? Any spasm of these muscles, thyroarytenoid muscle or interarytenoid posterior cricoarytenoid muscle, any spasm will see the stiffness of the vocal cords. Okay, that
okay.
is increased stiffness. Decreased stiffness will see in the paralyzed vocal cords. Suppose all these nerve supply is there, na? Any problem in these nerves, so then we'll see the paralysis of the vocal cords. In paralyzed vocal cords, there is no mobility of the vocal cords and also stiffness of the vocal cord will decrease. Okay.
Okay, sir.
So mainly you should understand the nerve supply of the larynx so that you can understand the diseases of the larynx. Okay. And also any disease which is affecting the size, stiffness of the vocal cord and also approximation. So mainly approximation is depends upon the innervation, nerve supply of the vocal cord and also muscles, thyroarytenoid muscle and vocalis muscle. So these interarytenoid, posterior cricoarytenoid, these are helpful for the adduction and the abduction of the vocal cords. So which is the abductor of the vocal cords? Which muscle is the abductor? Abductors of the vocal cord. The only muscle which is having the function, that is the abduction. Malik,
Sir, posterior cricoarytenoid, sir.
okay. Adductors,
Adductors are cricothyroid, lateral cricoarytenoid, interarytenoid, thyroarytenoid.
so many muscles are there for adduction. Lateral cricoarytenoid, thyroarytenoid, and the interarytenoid. So only posterior cricoarytenoid, which is a abductor. So for normal
Yes, sir.
voice production, the adduction and the abduction also is very important. Okay. So the movement
Okay.
of the vocal cords. So that is purely depends upon the nerve supply of the vocal cords and these muscles, laryngeal muscles, intrinsic muscles of the larynx. Okay.
Okay, sir.
So today's topic is voice and speech disorders of the larynx. So if there is any problem, size of the vocal cord, position of the vocal cords, stiffness of the vocal cords. So first we'll see the hoarseness of the voice. What is the exact definition? When do you call it is the hoarseness of voice? So it is change of voice from normal to a hoarse voice or rough voice. Then that is called the change of voice to the rough voice, that is the harshness of voice. So it occurs due to the pathology affecting the vocal cords or the glottis. So glottis means vocal cords, the space between the two vocal cords, we call it as glottis. So as I already mentioned, any pathology which is affecting the movements of the vocal cords or approximation of the vocal cords, approximation is nothing but adduction. So if they are meeting in midline, that is called the adduction. If they move away from the midline, that is the abduction. So approximation of the free edges or medial borders of the true vocal cords and tension of the vocal cords. Tension also is depend upon this thyroarachnoid muscle. Thyroarachnoid muscle is a tensor. So again, this tension of the thyroarachnoid muscle will depends upon the nerve supply of the thyroarachnoid muscle. So which is again by the recurrent laryngeal nerve. Right and left. Right side is by the right recurrent laryngeal nerve. Left side from the left recurrent laryngeal nerve. So tension and size of the vocal cords. So size usually normal. So simple congestion, suppose if there is any inflammation in the larynx, like in case of the acute laryngitis, chronic laryngitis, there will be some amount of edema because of the inflammation, acute infection or inflammation. So that kind of diseases also will affect this quality of the voice production. So these 4 points are important. That is the movement of the vocal cord, approximation of the vocal cord, size of the vocal cord, and tension of the vocal cords. So any pathology which is affecting these 4 functions of the or 4 physiological properties of the vocal cords will cause the change in voice or harshness of the voice. So you should be able to differentiate the harshness of voice from the muffled voice and the breathy voice. These are the different conditions. So harshness is produced if there is a problem in the glottis or in the true vocal cords. So this muffled voice is totally different. We'll see the change of the voice, but it is not the harshness of voice. Suppose if there is any mass lesion or mass is present in the oropharyngeal region, then we'll get this kind of voice. The other name for the muffled voice is hot potato voice or hot potato speech. So any problem in the supraglottic region or hypopharynx or in the oropharynx, so there is some mass lesion in the mass effect in the supraglottis or oropharynx, hypopharynx. So then patient will have the altered voice, that is called the hot potato voice or muffled voice. So the vocal cords are not involved in the muffled voice or hot potato voice, but the problem is in the hypopharynx or supraglottis or oropharynx. So the second thing is the breathy voice. Breathy voice or whisper. It is due to the lack of proper approximation of the vocal cords. So on there is a leakage of the air from subglottic region into the supraglottic region in between the true vocal cords, in between the true vocal cords. So there is no proper approximation, there is no proper adduction of the vocal cords. So then we'll see these kind of breathy voice on phonation. So that is due to the adductor dysfunction. There is no proper adduction. So it is commonly seen in the bilateral adductor paralysis, bilateral adductor vocal cord paralysis. So unilateral also will see the breathy voice. So then coming to the various etiologies for these harshness of voice or change of voice. Just a minute. Coming to the etiology for various voice disorders, it may be congenital lesions in the larynx or inflammatory lesions or traumatic and malignancies, neoplastic lesions and miscellaneous disorders of the vocal cords. So in congenital lesion, if there is web is nothing but adhesion between the true vocal cords in the anterior commissure region, that is the laryngeal web. So that is during the development there is improper recanalization of the larynx. Then we'll see the persistence of the membrane between the two medial borders of the vocal cords, true vocal cords, that is the laryngeal web. So then we'll see in these cases there is no proper adduction and the abduction of the vocal cords in the laryngeal web. Then we'll see the voice change and any laryngeal cyst. So that will also cause the improper approximation of these vocal cords. Inflammatory conditions like any infection, acute and chronic laryngitis, traumatic conditions, voice misuse or abuse of the vocal cords. So those who are speaking in the high intensity speech or low intensity, then it will cause the voice abuse or misuse, mechanical trauma to the vocal cords. Accidental injuries, external laryngeal trauma also will cause the effect on the vocal cords. Iatrogenic injuries during the intubation, endotracheal intubation, tracheostomy. So during any surgical procedures of the vocal cords, then we will see this trauma to the vocal cords. And radiotherapy, radiation, post radiotherapy, there will be a fibrosis of the vocal cords. Then we will see some amount of change in the voice. Benign tumors and malignancies. So carcinoma of the larynx, benign tumors like polyps of the vocal cords, papilloma, cysts in the vocal cords, and also fibromas of the vocal cords and larynx. So vocal nodules, laryngeal edema, stenosis of the larynx, unilateral vocal cord paralysis, functional aphonia, and laryngocele. These are the miscellaneous conditions which affects the voice quality. So the other causes outside the larynx are the carcinoma of the esophagus, carcinoma of the thyroid. These will cause the fixation of the vocal cords by the tumor infiltration and also paralysis of the vocal cords by affecting the either recurrent laryngeal nerve, most commonly, or superior laryngeal nerve. Pulmonary tuberculosis also will cause the apical lobe of the pulmonary tuberculosis will affect the paralysis of the recurrent laryngeal nerve. Diabetes, syphilis, and the cardiac and thyroid renal diseases, systemic diseases also will affect the quality of the voice production. So once you have got a patient of this voice change or harshness of the voice patient, so you should take the proper history, clinical examination, investigations to rule out any systemic diseases, and the treatment according to the diagnosis. You should treat the patient. So the main complaint, these patients will present with the harshness of voice or change in voice or inability to produce the proper voice. So first you should take the proper history. Detailed history is very important to know the what exactly the cause for the harshness of voice. So age of the patient, suppose it is in the neonates or early in the childhood, you should suspect some congenital laryngeal problem. So in case of any other inflammatory features like fever or sore throat or odynophagia, pain during swallowing, so then you should suspect some infection etiology in the larynx or surrounding the larynx like pharynx. So you should rule out like this. You should ask the entire history, proper history, onset of the symptoms, sudden or gradual in the onset. So if it is a sudden onset, then you should suspect some mass lesion or some paralysis of the vocal cords. If it is a slow in onset or gradually progressive in onset, you should suspect some mass lesion slowly growing in the vocal cord region and also causing the persistence of this harshness of the voice. One more important uh, history wise, one more important point, you should ask the patient the duration of the harshness of voice. So in old age people with the duration more than 3 weeks, definitely you should suspect the malignancy in the larynx. So persistent harshness of the voice in old age people, especially in the males with the history of the smoking and alcohol consumption, you should suspect the some amount of pathology in the larynx, and then you should inspect the larynx, that is by the laryngoscopy, rigid laryngoscopy or flexible laryngoscopy, to rule out the vocal cord pathologies like either benign or malignant lesions of the vocal cords. And also you should ask the patient whether that hoarseness or change of voice is, whether it is persistent or intermittent. So persistent means you should suspect some pathology in the larynx. Suppose it is intermittent, then you should not worry about that. So if it is a persistent and it is for the longer duration, definitely there will be some problem. Either size of the vocal cord will alter, or the function of the vocal cord by the, if there is any paralysis of the vocal cords, either size or function or approximation. So, and also you should ask the history of trauma. Is there any history of trauma, history of intubation, history of recent surgeries under general anesthesia? So before giving the general anesthesia, the anesthetist will intubate the patient by the endotracheal tube. So during that period also there is a chance of trauma to the vocal cords. So all this history is very, very important, and also age of the patient and also occupation of the patient. So you should ask the patient any history of voice abuse or voice misuse, and what is the occupation of the patient. So those who are outside students.
Yes, sir.
Yeah. So after thorough history, voice abuse, voice misuse usually seen the teachers, outside vendors, or marketing persons. There will be a voice abuse. So that will also will cause the this harshness of voice or sudden development of the vocal polyp or vocal nodules. So that's why occupation of the patients also very, very important in history taking. So occupation, the onset of the harshness of voice, duration, persistent or intermittent, any variations, age of the onset of the this age at the time of the onset of the harshness of voice, whether it is congenital or acquired problem, and also any associated systemic symptoms and any fever to rule out the, and also any history of trauma, any history of recent surgery or ICU admission also will cause the sometimes endotracheal intubation. So after thorough history, you should examine the patient, detailed clinical examination by a qualified person, that is usually by the ENT surgeon, will examine the larynx by using the flexible laryngoscope or rigid laryngoscope to rule out any problem in the larynx or in the vocal cords. So we should examine the oropharynx, hypopharynx, laryngopharynx or hypopharynx, examination of the neck, larynx, any lymph nodes in the neck, and also systemic examination to rule out any other CNS problems, CVS, respiratory system problems, like any lung pathology also will cause the paralysis of the recurrent laryngeal nerve, or sometimes dilated left atrium also will cause the compression over the left recurrent laryngeal nerve, then patient will have the harshness of the voice. Any CNS problems also, skull-based lesions will cause the vagus nerve injury, and also the patient will have the hoarseness of voice, unilateral or bilateral vocal cord paralysis, depending upon the. So trauma after examination, other investigations to rule out the systemic diseases, hematological investigations, then radiological investigations like X-ray test to rule out the any problem in the lungs which is causing the recurrent laryngeal nerve paralysis. So like tuberculosis or malignancy of the lower respiratory tract, X-rays of the soft tissues of the neck to rule out any malignancy in the neck or in the thyroid region, X-ray of the larynx with contrast laryngoscopy, barium swallow to rule out carcinoma esophagus. So carcinoma of the esophagus also will cause the direct laryngoscopy and microlaryngoscopy. If there is any lesion over the vocal cords, then we should, with the help of the microlaryngoscopy, we'll take the lesion for the histopathological examination. In direct laryngoscopy, we can assess the mobility of the vocal cords, any other lesion, and we can also take the swab for culture and sensitivity from the larynx. So, and also if you are there is no lesion in the larynx, but there is a paralysis of the vocal cords, to rule out the surrounding lesions, we should do the pan endoscopy, which includes the nasal endoscopy, esophagoscopy, bronchoscopy, and the direct laryngoscopy. So that is to rule out the any malignancies in these areas: nose, esophagus, lower respiratory tract, that is the trachea and the bronchi. Students,
Yes, sir.
yeah. So then coming to the treatment, after thorough history and the local examination with the help of the laryngoscope, bronchoscope, all those things, pan endoscopy. So we should come to a conclusion, that is whether the problem is either infective etiology or trauma or paralysis of the vocal cords or any vocal nodules, polyps. So if there is any lesion like benign lesion, we should excise the lesion completely by using the microlaryngoscopy. If we are suspecting any malignancy, we should take the biopsy. Then we should treat the patient accordingly, depending upon the stage of the malignancy, either total laryngectomy or surgical treatment, or combined surgical and the postoperative chemoradiotherapy, depending upon the stage of the disease. So if it is a benign lesion, we should remove the lesion entirely by using the microlaryngoscopy with the help of the laser or cold instrument. So treat the cause. If it is an inflammatory lesion or because of the voice abuse, misuse, Then we should instruct the patient a proper use of the voice, absolute voice rest, and anti-inflammatory agents and the steam inhalations. So steam inhalations by using the soothing agents like tincture benzonium and menthol or eucalyptus will helpful for the to decrease the to loosen the secretions and to improve the quality of the voice. If it is infection, we should give the antibiotics and the steam inhalation therapy, and also followed by the proper speech therapy. Because of the if it is because of the voice abuse misuse, then you should instruct the patient for the proper voice use. So then coming to the disorders of the voice, disorders of the intensity, pitch, resonance, and the phonation. So in intensity, so if it is aphonia, complete loss of the voice, complete loss of the voice, that is called the aphonia. So bilateral vocal cord paralysis or laryngectomy. Laryngectomy will remove the entire vocal cords. There is no question of voice production. So we can rehabilitate the patient by post-surgical treatment with the other electrical larynx, electrolarynx, or voice production by the esophagus. Those are the different things. So, but the patient will have the permanent loss of the voice in case of the carcinoma of the larynx. Will remove the entire larynx, and bilateral vocal cord paralysis also. If it is during the for the bilateral vocal cord paralysis, the most common cause is the post-surgical treatment. Most of the time, post-thyroidectomy or any blunt injury to the neck will cause the paralysis of the vocal cords. Both the vocal cords will remain in a lateral position. There is no proper adduction. Then patient will have the permanent loss of the voice. That is the aphonia. So these are the disorders of the intensity. Dysphonia due to phonation by the dysphonia plica ventricularis. So there is one condition where you will see the production of the voice by the false vocal cords. Those are the ventricular bands produced by the false vocal cords. Voice is produced here. The voice is rough voice, low pitched voice, and the unpleasant voice. So that is because of the if there is problem in the true vocal cords, the function of the true vocal cords is taken over by the false vocal cords. Then we call it as dysphonia plica ventricularis. This is important question for you, 4 marks question. Dysphonia plica ventricularis. So if there is a problem in the true vocal cords, the function of the voice production is taken over by the or compensated by the false vocal cords. Then we call it as this is the dysphonia plica ventricularis. So we'll see in the this is in the post paralysis of the true vocal cords or cordectomy. If there is lesion over the true vocal cords, will remove the part of the vocal cords or will remove the entire vocal cords. So paralysis or removal of the vocal cords, or sometimes without any lesion in the true vocal cords, there is a functional aphonia. So in that case also there is a voice is produced by the false vocal cords, that is called the dysphonia plica ventricularis. Dysphonia plica ventricularis. So there is one more condition, puberty dysphonia or puberphonia. Puberty dysphonia or puberphonia. So this is we'll see in the exclusively in the males in the adolescent age group. So usually the childhood voice is high pitched voice. So there is persistent of this high pitched voice in the adolescent males, that is called the puberphonia. So those who are dependent on the parents, psychological dependent Students?
Yes, sir.
Yeah. Sorry for the interruption. There is a lot of power cuts here. Okay. So puberphonia is persistence of the childhood voice in the adolescent males, especially in the adolescent life. The size of the larynx will increase in males. So the length of the vocal cords will increase. Then we'll see the low pitched rough voice compared to the childhood voice. Usually you'll see the high pitched voice in females and low pitched voice in the males. So then coming to the disorders of resonance. Chanakya, able to hear?
Yes, sir.
Okay. So we have seen the disorders of intensity, disorders of pitch, high pitch, low pitch, and the break in pitch. So in break in pitch, you'll see the spasmodic dysphonia. If there is any spasm of the adductors and the abductors of the vocal cords, you'll see the break in voice. So sudden break in the voice. So intensity is aphonia. These are the resonance, disorders of the voice resonance. So there is hyperresonance and hyporesonance. So hyperresonance will call it as rhinolalia aperta. These two conditions also important 2 marks or 4 marks questions in the final examination. So if the voice is produced by the vocal cords, but the resonance to the voice is coming from the oropharynx, hypopharynx, nasal cavities, and paranasal sinuses. So if there is any obstruction in the nose and nasal pharynx, then we'll see the hyponasality. So that is called the rhinolalia clausa. If it is hypernasality, that is called the rhinolalia aperta. So for the causes for the rhinolalia clausa is obstruction in the nose, simple allergic rhinitis, turbinate hypertrophy, nasal polyp. So any other mass in the nose and nasopharynx will cause the loss of voice resonance. So that is the rhinolalia clausa. So in case of submucous cleft palate or cleft palate of the soft palate or incomplete closure of the nasopharynx, then you will see the hypernasality. Okay. So next class we will continue the vocal cord paralysis. Students,
Yes, sir.
okay. So these are the disorders of the speech. Okay, final aphasia, dysphasia. If there is any problem in the brain, then we'll see the aphasia, dysphasia. Dysarthria is problem in the articulation and stammering. So this is functional disorder, repetition of the words, that is called the stammering or stuttering. So these are the disorders of the speech: dysarthria, stammering, dysphagia, aphasia. Okay, speech therapy and psychotherapy is important for this stammering or stuttering dysarthria. Okay, so this is about the disorders of the voice and speech. Next class we'll discuss the various reasons for the vocal cord paralysis. Okay, recurrent laryngeal paralysis, superior laryngeal paralysis, and vocal cord paralysis. Okay,
Yes, sir.
we require 2 or 3 more classes to complete the larynx. Okay, one is paralysis of the larynx, second thing is the benign tumors, and third one is the malignancies of the larynx. Okay.